Hello, and thank you for joining this video editorial series titled Advances in Best Practices in the Utilization of Novel Agents in Metastatic Breast Cancer. In oncology, oral oncolytics account for 25 to 35% of the oncology pipeline. And when treating metastatic breast cancer patients, oral CDK4/6 inhibitors offer patients another option, a very important option in their breast cancer treatment. Today, we're going to explore clinical and patient benefits of the CDK4/6 inhibitors, the multidisciplinary approach in treating patients, and the overall best practices for use of oral oncolytics, specifically the CDK4/6 inhibitors. I'm Dr. Joyce O'Shaughnessy. I'm the chair of breast cancer research at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. And today I'm joined by Michael Reff, a pharmacist and executive director of NCODA, the National Community Oncology Dispensing Association in Cazenovia, New York. And later in the series, you'll also hear from Dr. Sarah Taleni, assistant professor of medicine at Harvard Medical School and attending physician of medical oncology at the Dana-Farber Cancer Institute in Boston, Massachusetts, and Lindsay Shaw, a nurse practitioner at Dana-Farber Cancer Institute in Boston as well. And you'll hear from Dr. Kate Jeffers, an ambulatory oncology clinical specialist at the University of Colorado Health in Colorado Springs, Colorado. Thank you so much for joining us, and let's begin. To kind of put it into a real life context, like the oral CDK4/6 inhibitors, which have become the #1 go-to in the metastatic setting for ER-positive metastatic breast cancer. Patients are on them for a long time, too. And we have three. We have palbociclib, ribociclib, and abemaciclib. And all of them show very big improvements in progression-free survival, doubling the amount of time in the first-line setting the patients are on these agents compared to endocrine therapy alone. So, of course, they're combined with the aromatase inhibitors. And then second line, they're combined with fulvestrant. And just recently at ESMO and then published in the New England Journal of Medicine, it was shown that when fulvestrant is combined with palbociclib for patients who had prior aromatase inhibitor and didn't have really highly refractory disease, like blew through endocrine therapy, they got some benefit from it, and then they went on to fulvestrant plus palbociclib, then indeed there was a survival advantage for getting the CDK4/6. So that's really the first in phase 3 survival advantage that we've seen. Now, it was not in the overall treated population, it was in the sensitive population, but most patients fell into that category. It was only about 20% that were the really refractory. So it just shows you the emerging importance of these agents, Sure. But they have toxicities, and for most importantly, we've got monitoring of the CBCs with the neutropenia of palbociclib and ribociclib, and that does lead in a fair percentage of patients to the need for dose reductions, and how to integrate that with avoiding the waste of having somebody receive their next month's supply only to realize that's the wrong dose. Is a big issue basically. Sure. And so on that, how does that work in terms of the dosing, with the specialty pharmacy versus the in-house, for example?
Sure. Yeah, no, great question and great lead-in. So we're fortunate, our patients are fortunate that they have 3 options in a space that is just new, relatively new in the last 4 years or so. And this innovation has allowed us and allowed the patients to help maybe even bridge them to the next therapy that hasn't been discovered yet. And that's what I think the CDK4/6s have really done for our patients and our practices. But what you talked about a little while ago is some of the issues with dosing and toxicities and the efficacy profiles of these compounds. They're relatively similar in most respects, but they do have some nuances to them that we're well aware of. And I think it helps the clinician when they have discussions with the patients on which product to select. And then in the medically integrated dispensing or the medically integrated pharmacy team, when we have conversations with the prescribers, whether it's yourself as an oncologist or an advanced practice professional that's helping to decide a course of therapy or a treatment regimen, the medically integrated team can also help look within the EMR. And that's the benefit of having that in-house continuity of care that a practice can provide, where a specialty pharmacy really doesn't have the, not only do they may not have the expertise, but they don't have the infrastructure, because they don't have the electronic medical records that we do at the practice. And so if like an Encoder practice, we utilize the electronic medical records to the fullest extent possible to provide additional value to the patients and the whole care team. So we can interact with prescribers on what might be the best choice. And not only on the selection, but also on the maintenance. And you mentioned dose reductions. How do we manage that? And we work collaboratively in coordinated efforts with our medically integrated team.
Yes. I'm always calling my pharmacist and saying, okay, is a proton pump inhibitor okay here, you know, et cetera? Remind me of the food, because, you know, palbociclib, for example, should be taken after food, but that's not the case with ribociclib and abemaciclib. And as I recall, it's okay to take a proton pump inhibitor, but I'm always having to call and double check that. And, you know, obviously, if someone's had a history of some marrow that's been a little bit on the, you know, kind of more sensitive side, then we got to be careful of those CDK4/6 inhibitors that really cause myelosuppression. Maybe we want to start at a lower dose, you know, for example, and then the monitoring, and then how to time what the dose is that you're going to give next, you know, before you know what the counts are going to be, et cetera, you know?
And I think that's exactly a great example of where the pharmacy team or the medically integrated team, whether it's the pharmacist within the pharmacy itself, or whether it's the oral oncology nurse navigator, that's taking a look at, is the patient coming in on schedule to see how they're doing, right? And if there's a refill on a prescription, maybe it's not necessary because the patient hasn't followed up on the scheduled treatment, the treatment schedule that the prescriber wanted them to. And by utilizing that EMR and fully taking advantage of the information and then communicating back to the prescribers when they have that interaction that we can have, because we are medically integrated, the patient is in front of us, or the patient is on the phone, we know who they are intimately, communicating back to the prescribers on information that we gain or glean from our patients.
You know, you just brought up something that I have known for a long time in practice, that some lives that are lost in the curative setting because we didn't have systems in place to see who wasn't coming back, who wasn't filling those scripts. And they don't take their endocrine therapy, we know for sure that their outcome is worse. And the CDK4/6 inhibitors before long will be in the adjuvant curative setting. But even now in the metastatic setting, you know, they're not going to get the benefit if they're not filling the scripts, if they're not coming back and getting them renewed. And we haven't had that kind of infrastructure and practices, you know, to be able to really make that happen for patients.